All right, thank you very much, Lynn. And lovely to see everybody. And I do apologise if I've got this wrong. I am a consultant rheumatologist, but I'm also, as Lynn said, Director of Clinical Studies at the medical school, so have strategic and operational oversight of all the clinical training for undergraduates. And I sort of thought I could have talked about the medical school because you all know the medical school and only some of you might have an interest in rheumatology, but I thought I'd go for rheumatology. But what we can do is the Q&A at the end. If you want to ask anything about the medical school, please don't feel wedded to the subject that I covered. And I'm so glad I chose rheumatology as a speciality because I entered it at a really, really interesting time. And a time at which people might have said, the fat lady's son, there's nothing for you to do, because I entered at a time when there were not one, but two major advances. One was in therapeutics, which was the development of biologic treatment, so antibodies that target key pathogenic players in rheumatoid arthritis, that was one. And the other was in diagnostics, with a completely new diagnostic test, which brought its own excitement and challenges. And I think you're lucky if you get one. If you get two as a trainee, that's just bliss. And rheumatology has treated me very well ever since. So I'm going to touch on both. They are my favorite subjects. So let me just see if the slides will advance. So rheumatoid arthritis is an old friend back in antiquity, but the first artistic impression we think of it is this Rubens of the Three Graces. This is the first Grace on the left from 1638, and her hands have, I hope you can see my my pointer, her hands have, her right hand has a destructive arthritis. Now the purists might say that could actually be Jacquet's arthritis that you see in lupus, but I'm happy to accept that it's the first depiction of a rheumatoid in art. But the disease itself wasn't reported first until just the turn of the 19th century. And how about this for a front page of a PhD thesis, humbly submitting that there might be a different form of arthritis to the classic gout that had been described for decades and hundreds of years. And so Beauvais had noted across Paris, across his travels, that there was a different form of arthritis. We knew gout as a disease principally of older men, wealthy men with a good diet and alcohol intake. And Beauvais made the really cardinal observation that there was a different form of arthritis that affected women, and it affected hands and feet and was independent of diet or alcohol intake. And that was an absolute key discovery, and he submitted that as part of his PhD. We've got some alums speaking to the Oxford Medical alumni. Here are two of our more famous ones. Renoir had very disabling arthritis. In fact, his later artwork was done by mouth. And Christian Bernard, transplant surgeon, also had rheumatoid, although I don't think it threatened his career. It came on with a vengeance after his surgical career had ended. My favorite alum is Dorothy Hodgkin, who, a fabulous woman, a specialist in X-ray crystallography, who won the Nobel laureate for her description of insulin, sitting there next to her in 1964. And I have to just share as a wry remembrance, although the problems still persist for women in science, of how this was reported in the press at the time. Plus ça change, as they say. Anyway, I will not make this a talk about women in science, technology, engineering, and medicine, although that is another favorite of mine. So this is the classic rheumatoid arthritis, the symmetric, distal, symmetrical, deforming arthritis. And if you Google, which I tell my patients not to, this is what you see. After years of inflammatory burden in the hands, you get this enormous joint lining that swells, becomes hot and painful, the joints are stiff and sore, and macrophages transform into osteoclasts, degrade bone, and this is what you are left with. This is not what we see anymore. I do see this very rarely in patients who have been through the service for many years, but this is what I see in the early arthritis service. Much, much more subtle changes. So the disease focuses at the MCPs and the PIPs, so there is swelling here with loss of guttering. I think you can probably observe it more clearly here in the proximal interphalangeal joints. These joints will be very, very stiff and uncomfortable with limited grip. What is interesting and always a diagnostic help is that the DIP, the distal joint, is spared. And that happens all the time in rheumatoid, and that's very interesting biologically. It's helpful when you see a patient to help you make the diagnosis, but actually why? And as I tell my students, every time you're told something, ask the question why. What is it about the distal joint that protects it, whereas the proximal struggles? And is there something we could exploit in the biology of that distal joint that's not there in the proximal that could perhaps prevent disease? And that is that sort of thinking that I'm going to refer to throughout the talk and what has been of huge interest. These hands look milder than the ones I showed you before, but the impact of rheumatoid is absolutely devastating. And I'm very grateful to some of my patients for sharing their thoughts on having rheumatoid. And I'm just going to give you a moment to read these. Doesn't matter how many times I read that last quote, just gets me in the pit of the stomach every single time. So what have we been doing about this devastating disease? Well, back in the day, we used willow bark. Not entirely a daft idea because it has an active component not a million miles away from aspirin. So chewing willow bark had its utility. But this is the sort of timeline, if you like, of rheumatoid treatment with some key lines in the sand. One was 1950 and Hensch's discovery of prednisolone, which was a game changer across all inflammatory disease. Coming out into the sort of late 80s, methotrexate, which is now our go-to disease-modifying anti-rheumatic drug. Fabulous outcomes for patients in whom it works. And then as you breach the 2000s, we hit the first biologic therapy. Antibodies directed at key cells and inflammatory cytokines that drive the disease. And one of the things that I love so much about rheumatology is, like oncology, it is one of those subjects where understanding the science underpins therapeutics. It is by understanding how and why the disease happens and is perpetuated that serves to help us with therapeutics. I'm not going to go through this slide in detail. This is not a talk about pathogenesis, but I'm going to highlight the main players. So the main issue, obviously, in rheumatoid is this enormously thickened joint lining, the log, which is painful and stiff, the cartilage, which is degraded, and the bone that is degraded. And the key players here are two cells, the T cells, the B cells, and two cytokines, TNF. Really the low-hanging fruit. It was the one that was waiting to be discovered, and IL-6. And circulating IL-6, TNF, orchestrate B cells, T cells, amongst other players. And you can look at this at leisure another time, and I've got the citations on all of my slides, but they orchestrate this inflammatory burden that disables the patient and degrades their bone. But knowing this, you know what to do about it. And so we've got a host. I'm trying to get rid of this little there we go. We've got a host of biologics. We've got a host of way of targeting TNF, IL-6, et cetera, TNF, as I say, was the first one to come online. And that's the one for which we have the most number of drugs, all ending in MAB, monoclonal antibody directed against TNF, with the exception of etanercept, which is quite clever. That's not an antibody that destroys TNF, it's a decoy receptor. So it's a TNF receptor bound to an antibody which circulates. The TNF sticks to the receptor but doesn't get cell signaling. So works just as effectively as the others. So we have a host of anti-TNFs, ways of destroying that inflammation cytokine. We can also destroy IL-6. Well, we don't destroy it, but we block its receptor, both the cell-bound ones and the circulating ones. And so then, of course, you don't get inflammatory cell signaling. Or you can take out a cell. Now, this we've inherited from our oncology colleagues. Anybody who's known anyone with lymphoma, rituximab is going to be a very familiar old friend. It depletes B cells highly effectively through a host of different mechanisms that are listed there. And it came on really after the anti-TNFs in terms of discovery. The B cell is a cardinal cell in rheumatoid. Yes, it produces antibodies, and rheumatoid's an antibody-mediated disease, but it also presents antigen, it can produce cytokines and so on and so forth. So a useful target to hit. And the final cell is the T cell. And this is the one, this always slightly does my students in when I come onto this at the end of the biologics lecture I do for them, because the biology is more complicated than the others. But it's another example of knowing how knowing the biology informs the therapeutics. So you're all sitting there with your T cells wandering around and some antigen presenting cells presenting foreign antigen to T cells. And the first signal is the MHC TCR1, which you will recall, but there are a host of second signals. One of the second signals that's required for activation is this one here, the CD8086 and CD28. But what is so good about the T cell is if it becomes activated through that pathway, it activates and then breaks. It produces a break to just put a leash on its own puppy so it doesn't go completely crazy. And what the biotech company did was said, well, look, the T cell's involved in rheumatoid, but we don't want to squash it, but we know that it can control its own behavior. Why don't we just exploit that? So what they did was took the very chemical that the T cell produces to pull back on its behavior, bound it to an antibody so it lived longer, and there you got a drug. It's just so elegant. It's just such a brilliant use of understanding the fundamental principles of science. I love it. Do they work? Yes. Now, I'm not going to turn you into rheumatoid trialists, and this is only one of the clinical trials that I'm going to show you, but this is the big hitter. This is the ATTRACT study that he's called Ravinder Maini, but everybody calls him Tiny Maini, published in 1999. And I'll take you through this just swiftly so you understand the scale of how well it works. So this is looking at swollen joint count. This is looking at something called the ACR20, an improvement score. And there's another one here. Oh, in fact, sorry, those are two versions of the ACR20. For some reason, the slide has dropped my CRP one. So we'll just look at these across here. So if you look at the swollen joints, this is the change in baseline. This is placebo, and this is with the infliximab, and you can see clear daylight between the two lines there. Here is infliximab at 2 different doses. Here is placebo, and this is patients responding, and you can see daylight between the two. But it doesn't really matter how much trial data you see. The difference is what the patients tell you. And I have a beautiful quote from a patient of mine whom I'd known for many years, who then went on to TNF inhibition, and his disease went straight into remission. And I love this quote. That's all he had to say about what it was like when his rheumatoid was under control. And it's better than any piece of data. So there we go. Was our job done? Was I training to become a consultant in a subject that had had its heyday because we had biologics? What is left to do? Lots. But I am going to tell you, this is slightly the world according to Swales. I do apologize. I have chosen subjects that I love and speak to my heart, and that I've been involved in on the clinical trials unit. There is a host of other stuff that I could have presented, but time is short, and I went for what speaks to me most. What am I not talking about that I think is important for people to think about? Well, the targeted therapies, these antibodies, they're humanized, but they're not you, right? They're made to look like a human, but they're not made to look like you, human. And the risk is that inevitably you'll get immunogenicity as a consequence, and your body will attack the thing that is trying to help you. I'm not going to touch on small molecule inhibitors. So what I'm talking about are the large cell signaler ones. So dealing with the signals coming onto the cell, not what happens within the cell once that signal has reached. But we now have JAK inhibition, which is hugely effective. We also have new targets. I'm only talking about the immune system in terms of the Bs and T cells. I'm not talking about dendritic cells and fibroblasts. And these are probably the next area that we need to be moving into. And my favorite thing of Trojan horses and guided missiles, it's all very well to modulate the immune system to reduce problems in the joint, but actually you only want the immune system modulated in the joint. I quite like having TNF. It gets rid of my little cancer cells that might be popping up here and there. It certainly manages my TB that I've inhaled very effectively, but actually where I need it is in the joint where it's overexcited. So how can we get a decent drug to the right place? And is there a Trojan horse? Can you get a drug delivery method that it is ineffective anywhere else except where it needs to be? And with nanosphere technology, that's coming online, which is hugely exciting. I think one big question for all rheumatologists, but it's all trialists, is what is effective. Now, most clinical trials rely on something called the MCID, the minimally clinically important difference. What is it that the patient reports or you measure that is enough of a difference to be worth talking about? And for many trials, particularly the early ones, they used the ACR 20, American College of Rheumatology 20, which effectively means that you feel 20% better. But if you think back to my 4 patients who shared with you how they felt, 20% better than absolutely wretched is still pretty poor. So I think there's a cultural question about what constitutes efficacy. But even if we use the ACR 20, let's look at this. So this is comparing a number of biologics, etanercept, infliximab, adalimumab, with straightforward methotrexate, no biologic. Okay, the numbers are better, all right? 71% of people reach ACR 20 versus 14.5. Well, that is super. I totally accept that. But it does mean that 30% of patients don't even feel 20% better, right? And you've got the same at the top end. So 15% get to ACR 70, but a tiny amount get beyond that. So not only is there unmet need, but there's also a ceiling effect. So the two ends of the curve of response are somewhat under-provided for, if you like. So we do have to try harder. The fat lady has not sung. She has cleared her throat for a whole new note. And we need to recognize what that is and try to attack it. So there's still an unmet clinical need. And really interestingly, there is disparity in clinical outcomes. You see this in clinical practice, that you have a patient who starts on a particular biologic therapy, and you're sort of all kind of enthusiastic, and this is going to kick it to touch, and you'll be fine. And they come back and go, no, this hasn't worked. Okay, so you try another one. You go from TNF to rituximab, and they come back and go, this still hasn't worked. Okay, then you try IL-6, or you try, and then you get to the 4th one, and you try it, and the disease responds, and they go, could you not have done that 9 months later? What are you playing at? But it's trial and error. It is trial and error. And on the one hand, if you're not thinking when you're in that situation, you can just go, oh, well, we got there in the end, job done. But actually what that says is the rheumatoid that you're seeing is not one disease. You see some patients with TNF-mediated disease, some with B-cell-dominated disease, some with IL-6, etc. And that was an absolute eye-opener, I think, for the community in the development of the biologics. Biologics are probes of pathogenesis. They're not just good for the patients, they're really good for scientists too. And that has led on to the whole notion of stratified medicine, the right drug for the right patient at the right time. If you come in with rheumatoid, is there something that I can test in any of you that would say, not only do you have this kind of, not only do you have rheumatoid, you have this kind of rheumatoid, which means you need this kind of drug. Now, it sounds fanciful, but our oncology colleagues have been doing this for years. If you have breast carcinoma, the first question anybody asks is it estrogen receptor positive? Because if it is, you get tamoxifen. If it isn't, you don't. You know, why can we not be as ambitious as that? And it's all in the understanding of science. So this is the first of the major initiatives that I'm going to talk about. PEAK, which is what I started doing. We were part of this large consortium of the pathobiology of early arthritis, and we were in it with Barts and Glasgow, a whole group of us who got together to ask that question. Is rheumatoid the same thing? Are all rheumatoid tissues the same, or are some different, and do they behave differently? And could the different architecture inform us of something, that some patients might do better or worse than others, or some might respond to different drugs? So this is the sort of thing I used to do to poor, well, not unsuspecting people. They did consent, but this is the sort of stuff that I used to spend my time doing before I moved to the medical school, doing minimally invasive synovial biopsy. And here's me taking a biopsy of the second MCP of a patient under ultrasound guidance. I don't know how well it projects, but here there's the sharp line of the MCP head. Here is the joint capsule and the joint lining, and there's a very sharp line here of the biopsy needle. And under local anesthetic, you just go in, take a biopsy of the tissue and have a look at it. We do know that synovial specimens are representative generally of a type. If you've got one type of synovial architecture, you're going to have it the whole time. but does it meet, are there different versions? And by gum, yes, they are. So this was published in Annals of Rheumatic Disease in 2019. The reference is there if you want to look at it in more detail. But this is the headline, that not all rheumatoid tissues are the same. And most people fall into these two camps, what's called follicular and diffuse, and some are porcine immune. So here are different stains, H&E, just picking out cellular architecture. The CD20 picks out the B cell, and you can look in this patient, for example, they've got lots of B cells, but all clustered away, almost like they've got tonsils growing in their synovial lining. Whereas this patient doesn't have many B cells, but by gum, it's got a lot of macrophages down here, the CD68. So does the follicular patient behave differently to the diffuse patient because their inflammatory architecture is different? This third cohort have got relatively little inflammatory tissue making its way into the joint. And that was, I think, the start, a platform for a whole new raft of work around this. So the main advances from Peake were that there are 3 distinct cellular pathotypes in the RA synovium, and actually they relate to different diverse phenotypes. So if you've got the high inflammatory infiltrate, then you do have worse outcomes. You tend to erode earlier, you tend to have greater disability scores and so on and so forth. And you tend not to respond to non-biologic treatment quite as well as if you've got lesser inflammatory burden. But of course, that then led on to the major question, does that inform the biologic? Because things like methotrexate just tend to damp down generally, they're not targeted. Whereas, of course, one might argue that this patient, who's got a very follicular synovium, a very B-cell architecture, would do better on rituximab than this patient who's got very macrophage-mediated disease, for example. But you've got to prove it, right? You've got to see if that's going to hang out. And this is what STRAP did. So stratification of biologic therapies by RA pathobiology. This, again, multi-center NIHR supported clinical trial in which patients had biopsies at the start of their treatment, were then randomized according to their biopsy stratification, followed forward to see how well they did in their disease and how well they responded to treatment. That sounds relatively straightforward, but this is what the trial looked like, and it was an absolute nightmare to deliver. It was enormously complex to design and deliver. And actually, a subgroup of these patients also had a biopsy after 16 weeks of their treatment. And for us who were trying to do these wretched things, it was a nightmare. First time they came, of course, they had joints like this, had massive. It's so easy to make a biopsy across the room without an ultrasound. It's gigantic. After 16 weeks of treatment, your target was like tiny. It got much, much harder. So this has now closed to recruitment. We've got 180 people in the trial, which we hope will be enough. The power calculation would suggest that it might be, but the data has not been published yet. So hopefully that will emerge relatively soon. But the next question, actually, which happened in tandem but has been published first, is does it help with second line choice? So if you've been put on TNF and you didn't respond to that, does it help you make further decisions? And that was the R4RA trial. Does synovial biopsy identify patients who will respond to their second line treatment? Again, an absolutely hideous clinical trial protocol. They're getting worse by the minute, it feels like. And here, patients were randomized according to whether they had their B cells, you know, those tonsils sitting in the joint. This was published in the Lancet in 2021 to great celebration. And in summary, and I'm not going to go through the whole trial for you. In summary, actually, it didn't take quite the wind out of our sails, but it's not as simple as looking at the histology. I think what the authors and all of us in the consortium were hoping was that you could just look at the biology, you could just look at the histology, and that would be fine. You'd look at it and go, you're G cell rich, you have this, you're G cell poor, you have this. Didn't pan out. What you have to do, which makes it much more complicated, much more expensive, and much less relevant in clinical practice, really, is to do RNA sequencing. If you do RNA sequencing on the biopsy, and that shows you that the B cells are poor, then you can go for an alternative agent and will do better. So it is the start of a signal, of stratified medicine, but it's not really, I see you in clinic, I do a biopsy, I call you a week later with the histology results and prescribe the right drug. But hopefully we will get there. So that's treatment, and those two big trials will have more and more data coming out of them over the next few years, which will be very exciting. But what about pathogenesis? What about the start of the disease? And I talked about this new diagnostic test, the anti-citrulline peptide antibody, the ACPA, was the new rheumatoid factor. So rheumatoid factor is a self-IgG or IgM, as you will all vividly recall from your rheumatology. Yes, I'm getting some nods. ACPA are autoantibodies against citrullinated peptides. So you're just sort of sitting here producing aggrecan, filaggrin, vimentin, all sorts of structural proteins. Some of you are citrullinating them. The smokers amongst you are citrullinating them faster than others, and then also developing antibodies against those citrullinated peptides. And the ACPA, these antibodies against those citrullinated peptides, are much, much more sensitive and specific for rheumatoid. You'll recall that rheumatoid factor is only positive in about 70% of card-carrying rheumatoid patients. This is in the order of high 90s. You know, you can't ignore it. But the really important thing is that they are there up to 10 years before you get arthritis. So you have immune tolerance breach before you get disease. And that has to beg the question, what can we do in that window of opportunity? While your immune system has been kicked, but you haven't yet got the disease, is there something that we can do? Can we step in? It also revealed the crucial link, as I've already mentioned, with smoking and with genotype. And this is probably a slight segue in the talk, but I had to put it in because this is my desert island data. You know, desert island discs? This is my desert island figure. If I only looked at one piece of scientific data for the rest of my life, it would be this. So this is from Lars Glasscock, who published this way back 2006. And he was looking at the interaction of genes, the new blood test, and the environment in terms of smoking. And let me take you through this. So this is a group of patients who carry the CCP antibody, this new antibody. And he divided them into smokers and non-smokers, because it's quite clear that smoking is bad. It's a risk factor for rheumatoid. And then he correlated it with the number of copies of an at-risk gene. I'm not going to go into the genetics, but there is something called the shared epitope, which is a high at-risk gene. So if you have the CCP antibody and you've got no copies of the gene and you're a never smoker, you're down here, you've got very minimal risk, right? If you've got one copy of the gene and you're a never smoker, your risk climbs a little bit. If you've got two copies of the gene, but you don't smoke, it climbs a little bit more. If, however, you're a smoker, that risk rockets almost exponentially. So if you are a smoker and you have two copies of the gene, i.e. a strong family history, and you're CCP positive, your relative risk of developing rheumatoid is up to 40 times the background population. And that has produced a huge area of scientific endeavor in terms of the interrelation between smoking and genetics. But what is so great about this data is this is in those patients with the abnormal, with that new antibody. If you test it in patients without that antibody, the signal vanishes completely. And it is just such an elegant representation of the interplay between immunology, gene, and environment. I just think it's brilliant. So can we do a preemptive strike? Sorry about that segue to evangelism, I do apologize. So as I said, the ACPA antibodies are there present for a decade before you develop arthritis, and they all climb. It doesn't matter what type of antibody you have, the antibody overall number of antibodies and the proteins against which you develop the antibodies amplify as you reach disease onset. So here's 15 years prior to disease, 10, 5. This is the point at which you develop arthritis, and you can see how it starts to climb. And in this particular area here, where it's looking at the specific titer of the result, look at that, how it rockets in the last 2 years. So surely there is something we should do in the last 2 years to try to prevent this disease from ever happening. And that is the EPICRA study. So if you look at rheumatoid pathogenesis, the early signal that comes out is the T cell. So B cell and TNF and all the other stuff I talked to you about biologics, it's all there. but the early signal comes from the T cell. And the EPIPRA study is run by Andy Cope, and Oxford was another recruiting centre. And it was asked a very simple question. It said, if you get people, not patients, because they don't have pain, people with this abnormal antibody, and you randomize them to no treatment at all or T cell modification before they develop arthritis, can you prevent the arthritis from ever emerging? Really lovely idea. We all got very excited. The slight problem is recruiting, because none of the people have any symptoms. So where the hell do you find them? Because there's nothing wrong with them. You're not treating patients, you're treating people. So the answer emerged in the Sunday Express. That is how you find people. You put it next to Lady Gaga and Cliff Richard and Victoria Beckham without many clothes on. And you release it to the Daily Express, and suddenly you get inundated with people saying, oh, my mum's got rheumatoid and I'd quite like to be involved, and so on and so forth. So that trial has now completed. The protocol has been published. It is close to recruitment, and that is another watch this space. I have to say, even if it demonstrates that using abatacept, using T cell modification early on would prevent disease, that's very expensive, actually. I'm not sure that it's going to fly past NICE or anybody else, but rheumatoid is a very, very significant health economic burden. So the maths might add up. But there is also the ethical thing of, you haven't actually got the disease yet and giving you a major immunomodulator. It's difficult. It's difficult. And patients have or recruitees into the study have struggled with particularly that question. My final point before Lynn and Emily start gesticulating wildly at me. I've already talked to you about smoking, and that smoking is a major risk factor for rheumatoid. And there's this interplay, as that lovely graph demonstrated, between smoking, genetics, and the abnormal blood test. But colleagues in continental Europe, I should say, have asked the question, is it the smoking or is it the lungs? And the answer is it's both. And in fact, it's not just the smoking. So ACPA positive patients, so these patients with the abnormal antibody have abnormal lungs before they get joint disease. So their lungs are the first to go. So if I turn to my medical students and say, rheumatoid actually starts in the lungs, they'll probably throw soft fruit at me, but the data would suggest that's true, that even before you develop joint pain, your lungs are starting to demonstrate the strain, not clinically, but it shows up on high resolution CT scan. The parenchyma is not quite normal. And if you do parenchymal biopsy, then you can see in an ACPA negative non-smoker, this increasing ACPA sensitivity, particularly in those who smoke, with a suggestion of an increased inflammatory infiltrate. If you look at the high resolution CT score with the quantitative scoring here, the ACPA positive patients have greater abnormality than ACPA. And if you do a bronchoalveolar lavage, there is ACPA enrichment in bronchial fluid. So there is no question that ACPA positive rheumatoid patients have higher levels of these abnormal proteins, and that this may be starting to drive their disease. Does that correlate with anything else? Well, yes, absolutely. It also correlates with the lymphocytic infiltration. So I'm just trying to get rid of the thing at the top because you can't quite see it yet. But with the ACPA positivity comes the inflammatory infiltrate. So this is bronchial tissue now, not just parenchymal. ACPA positive rheumatoid, look at all that inflammatory infiltrate, all this mass of lymphocytes here. This is ACPA negative rheumatoid, far fewer, and this is healthy, and this is tabulated here. So there is no question that it seems rheumatoid starts in the lungs, at least in ACPA positive individuals, with an immune tolerance breach, and then somehow makes its way to the joints, but then only some of the joints, and produces a very different form of cellular architecture when it gets there. And each of those steps produces another 5 or 6 questions. So in summary, rheumatoid is not a disease. And my students always look at me like, oh, when I say it, but it's not. It's not a disease, it's a syndrome. It's a funneling down into a shared clinical phenotype. It's a final common clinical pathway from a host of immune aberrations that we're only just starting to unpick. And if we can unpick those, then that will inform what treatments that we can use. we would hope that it's joint architecture. We would hope it's something as simple as the histology, but I think the disease is more complex than that, and it's going to need something like RNA sequencing, which might push it 10, 20 years further down the line, so we have the better technology. For those who haven't yet got the disease, but have, for example, a very strong family history, there may be a window of opportunity. It may get to the stage that up in GP surgeries up and down the country, there are notices saying, if you have a first degree relative with rheumatoid, come and have a blood test to see whether you're at risk. And there are treatment options available for you to, before it becomes a problem. Could it be a vaccine? Could it be early abatacept? We don't yet know, but the questions are being asked. And it may not be a joint disease at all. It may be a pulmonary disease with primarily joint manifestations. My husband's a respiratory physician and would probably freak if he heard me saying that, but it's possible. It's very strange that the first place the disease shows itself is in the lungs, not in the joints. So it's been a real pleasure to work with rheumatoid for the last 20 years, an extraordinary time to be part of an extraordinary subject. And I love this quote. I love C.S. Lewis anyway, but I love this quote, and that speaks to my career to date. So thank you very much for listening.